Welcome to this video demonstrating a use of a miLOOP to remove a pseudoexfoliation cataract with a moderately small pupil, and then the addition of a Hydrus microstent. So, as usual, here's the orientation, sitting temporal. We're going to start with 2% lidocaine with epinephrine, and this is over the nasal quadrant. I strongly believe in this part of the procedure to help decrease the sensation or make absent sensation when the Hydrus implant goes in later. I've had too many patients jump prior to using this technique, but this combined with the intraocular lidocaine seems to completely deaden the area. Now we'll make the standard cataract groove, but notice it's slightly corneal. Same for the paracentesis, and this is to avoid limbal vessels. If you get any blood at all, the view is impossible with the gonial lens. And there you see the 4 clock hour location of the paracentesis, oriented in between the two zones, the center and the implant site and the meshwork. This way, the same wound can be used for the cataract as for the Hydrus implant. That orientation and that location is extremely important to have a successful Hydrus implant. So when using the miLOOP, everything is very standard up to the point of phacoemulsification. This is just ordinary capsulorhexis, which I do make at the pupil margin. This particular case, the pupil is reasonably dilated for a pseudoexfoliation eye, so I used the pupil margin as my guide. Sometimes if it's a little smaller, I'll go underneath the pupil margin and make the rhexis slightly larger than the pupil. It's actually really helpful to tear along the pupil border. The edge of the iris actually helps guide the tear and prevent it from going radial. So for using the miLOOP, I always like a very healthy hydrodissection. Here I am with the Bing course going in reverse. I like to do reverse and forward. It doesn't seem to matter the order, but I just prefer to have something going subincisional to make sure that area is really freed up well. And then I'll go forward direction and make sure I achieve really nice loose rotation. There it is. So now I know my miLOOP will be able to pass without any difficulty. So to get the miLOOP going, we're going to put viscoelastic in the chamber, and then the miLOOP is placed inside the eye. I prefer a two-handed technique, which is contrary to what is typically taught. I don't feel the need for any nuclear stabilization. I think I have better control when I use both hands. The actuator is relatively stiff, and I find if I'm trying to use one hand to extend or retract the wire and hold it in proper position, it's a lot more challenging. So here I have two hands. I'm going to be turning it very, very slowly, and I'm looking for that reflex to appear. And we just gotta wait. This is a really slow process. There it is. So once that reflex appears, it goes a little bit further, and then I rotate backwards. Now here I am closing the loop, and I actually push the device forward as I pull the loop in. This is to counter the natural rotation. So here you see I really didn't rotate the nucleus very much, and watch this. As the wire loop opens up, it rotates the nucleus the appropriate amount. So you really don't need to do anything more than just maybe a 5 degree. And there's my reflex again. I'm going to wait for it to get into a beautiful position, and then same thing. I'm going to pull that loop together, and I'm pushing the device into the eye as I'm pulling. So that motion eliminates the need to have a second instrument. You really don't need to have anything for countertraction. Just close the loop as you're advancing the tip. And that I find that works extremely well and gives me a lot more control than trying to manipulate the wire with one hand and a second instrument with a second hand. So, as with all phacoemulsification, especially phaco-chop, getting that first quadrant out is really the key. Once that's out, there's space is created, and then it gets so much more comfortable. You can see with the miLOOP, making the quadrants, it's just great. Everything just comes straight up. I don't have to go chasing it. The pieces just come right to the tip. I am using bevel down with an Alcon Centurion machine. So once again, pretty straightforward phaco-chop. Once the miLOOP has done all the heavy lifting, I find these cases work really well. It's very low stress, does not put much work onto the zonules of the bag, which is so important in these pseudoexfoliation eyes. And it also avoids really the need for pupil stretching, which I also find really important in pseudoexfoliation eyes. The pupil tends to have a membrane and tends to bleed and become quite inflammatory. So here's a little trick I do. I have a piece there, so I actually take the chopper out to change the flow and allow that piece to go back to the tip. And there we are. Thanks to the miLOOP. I'm going to speed the video up here 3x because there's really nothing unusual about the IA. Just going to clean everything up. I do take a Kugelin hook and kind of move the pupil around just to get a little better view in there when I have a small pupil case. But other than that, we're just cleaning everything up, and then we'll get the lens in, and then we'll get over to the Hydrus part of this procedure. I do like capsule polishing. I think it really does help prevent fibrosis, and I think it also helps with the final lens position with better consistency. Okay, so here's our final cleanup. I have tried skipping this step because the next step is to put more stuff back in and then do the Hydrus. However, I do like to use the Myostat and a 1% lidocaine non-preserved solution to help deaden the iris. And I found if I don't clear out the viscoelastic, the Myostat and the 1% just doesn't get the job done. So here we put the Myostat in. I really do like this step for implanting Hydrus. I think it opens up the angle and just gets that iris out of the way. And then the non-preserved is really important because I find a small percentage of the population has nerves on the meshwork. And if you attempt to implant an iStent or a Hydrus without deadening those nerves, the patient will move suddenly. So at this point, we're ready to reposition everything for the Hydrus, and I like to completely reset everything. So I'll be telling the patient I'm popping the tape, I'm going to be turning their head, and we're going to move it away from them. And the biggest problem that I find is everyone wants to go back to the light. We just got through telling them the entire case, keep facing the light, and now we're telling them don't face the light. So what you can see here is I'm adjusting everything. We have to change the angle of the head, change the angle of the scope, change the oculars, readjust my seat. I'm getting everything set up for a basically it is a separate procedure. There is no relationship. I'm telling the patient to look away because I'm trying to get that en face view of the angle. Now notice carefully, this looks good, this is not good. And that's where people get into big trouble with Hydrus. Once again, looks good, not good. And the reason I'm struggling is the patient is trying to move their eye back to the light. So I will do whatever I need to do to get that en face view. And here I am repositioning the scope, repositioning their head. I'm still trying to get the right view. It's still not correct. So I'm going to do it again. And I really encourage you, take your time at this step. Make sure you have the correct en face view. And you'll see when we finally get it, you'll understand what I'm saying. It's a much taller version of the angle. There it is, right there. Okay, I'm finally en face. I've got a good attack angle. You must have this. Now that I have the attack angle, I stop. I take a deep breath. I meditate. I clear my mind and slow my heart rate. Nice big breath in, big breath out. Just really try to settle everything and release all that energy from the cataract surgery and from this struggle that I had getting to that view. And now we're going to take the Hydrus. It goes in posterior direction is the easiest way I've found to get it into the paracentesis. So I kind of zoom out to show you that. And then once it's in, then I flatten it out and put my lens on. And I'm going to bring the focus from the tip of the Hydrus, and I'm going to move the Hydrus posterior as I'm moving the focus posterior. So the focus is following the Hydrus. It's not on the angle. And now we're going to angle this up, and notice I try it. It didn't quite seat, so I'm going to do it again, and there we go. So there's a little bit of a 30-some degree angle upward to allow the Hydrus to go out flat. And that just seems to be the way this device is designed. When you go to do the implant, you cannot have the inserter at the angle of the meshwork. It will not go in properly. You have to angle your inserter up about 30 degrees. The other thing that is really impossible to show on this video is the third dimension. So this is an XYZ procedure, and that's one thing that makes Hydrus so challenging. And you saw maybe a little bit of the dimpling of the meshwork in. That's me pushing back down into the posterior wall of the canal prior to the insert. And there's just no good way to demonstrate that. So now once everything's done, I'm going to reposition the head back to neutral, redo my scope, redo everything so that I can get just a regular standard cataract view, so to speak, because I want to make sure the lens hasn't moved. I want to see if there's anything that needs my attention, the wound or something like that. This amount of bleeding is excellent. You want to see blood reflux into the eye. If you do not see blood reflux into the eye, it could mean you're in the wrong place, or it could mean you just had the eye overpressurized and filled everything with viscoelastic. In this case, I did like to do additional IA to remove that extra blood, although it will build back up. I don't always do a final IA in this position. So once I'm totally satisfied that I've got everything in the right spot, and I'm going to check my wound, you can see there's a little bit more blood reflux, which is just perfect. You really do want this. You have to coach the patients through the post-op period because this blood is going to ruin their vision for a couple days. I find about 3 days. And they may be a little disappointed because their neighbor had cataract surgery and saw the next day. But this is Cataract Hydrus, and thank you very much for your attention.